Hello, and welcome again to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier consisting of review articles centered on a major topic important to surgical oncologists. The series has published for over 30 years, and for our sixth podcast, we'll be discussing the July 2022 issue devoted to sarcoma. I'm John Vasallo, managing editor of the series here at Elsevier, and during this podcast, we'll discuss 4 articles from the issue: the new changes to the WHO classification of soft tissue and bone tumors, desmoid tumors, relevant trials in sarcoma and gastrointestinal stromal tumors, and immunotherapy and sarcoma. Leading this discussion will be our consulting editor, Dr. Tim Pollock, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the 2 guest editors of the sarcoma issue, Drs. Chan Rout and Alessandro Granchi. Dr. Rout is chief of the Division of Surgical Oncology at Brigham and Women's Hospital, surgery director for the Center for Sarcoma and Bone Oncology at Dana-Farber Cancer Institute, and professor of surgery at Harvard Medical School in Boston, Massachusetts. Dr. Granchi is professor of general surgery and chair of the sarcoma service at Italy's National Cancer Institute in Milan, Italy. Welcome to all 3 of you, and over to you, Dr. Pollock.
Thank you, John. As noted, my name's Tim Pollock, and I have the pleasure of being the consulting editor of Surgical Oncology Clinics. And for this volume of Surgical Oncology Clinics, we have 2 outstanding editors, really world-renowned surgeons and clinicians in the field of sarcoma. And we're absolutely delighted to have them here today on this podcast to discuss some of the articles from their wonderful volume. So welcome, Chan, and welcome, Alex. You are to be congratulated for putting together really an amazing team of co-authors that incorporated a number of really seminal articles on the topic of sarcoma and gastrointestinal stromal tumors. Today, we're going to be highlighting 4 articles in the volume, and we're going to start off with the article actually that Dr. Granchi, you were a co-author on with Dr. Schaefer, that talks about the WHO pathology and in particular highlights some of the updates. And as noted in the article, in 2020, the WHO classification of soft tissue and bone tumor incorporated a number of new changes to reflect some advances that have been made in the field of soft tissue sarcomas. And I'm wondering if you could discuss with us some of those additional changes and updates to the classification of sarcomas in the WHO schema.
So thank you very much, Tim, for the question. Indeed, the new WHO classification was developed at the end of last year and included several new entities, which were based on, number one, advances in molecular classification of tumors, and also number 2, on identification of new morphological entities. For example, in the adipocytic tumors, some rarer histology types were identified, and that are important to recognize because they may have a clinical implication. Among these, of course, the spindle cell pleomorphic lipoma, which in the past was used to be called or exchanged for an atypical lipomatous tumor, so an intermediate malignancy, which in fact is not. Other entities that have been identified in the recent WHO classification are those related to NTRK rearrangements. NTRK rearrangements has gained a lot of interest in the recent years because of the availability of NTRK inhibitors that are pretty much effective. This is particularly true in pediatric sarcoma like congenital fibrosarcoma, but also in the adult. So it's not very common, and it's not only happening in sarcomas, because NTRK rearrangements is something that can happen also in other tumors, like, for example, lung cancer or other type of tumors, but it happens also in sarcoma. And recognizing these entities is important because it has very significant clinical implication and a change in management.
So maybe you could just touch on that a little bit about the significant implications that it does have for change in management, and maybe highlight to our listeners, some of whom may not be as expert in sarcoma as you and Dr. Rout, about the importance of the pathologic diagnosis in driving clinical decisions and treatment, and how this new classification scheme has implications vis-a-vis treatment strategies.
Sarcomas are not a single disease. Sarcomas are a family of very many different histology types and molecular subtypes. So it is important to recognize and appreciate the difference in the type of tumors that you are treating, because this may require a completely different strategy, which may span from the use of chemotherapy, conventional chemotherapy, and/or radiotherapy and surgery, to the use of sophisticated and newer molecular target therapies. So, for example, I was mentioning NTRK rearranged tumors, and this actually today would benefit from the use of NTRK inhibitors, while all other sarcomas certainly don't. On the other hand, even histology types and subtypes are important even to decide, for example, the surgical strategy. This is typically the case for abdominal sarcomas, where having a differentiated liposarcoma would require, even from the surgical standpoint, a certain type of resection, which would be different from the one you would do for a leiomyosarcoma. And the same apply for the use of chemotherapy. In the liposarcoma, you would use one type of chemotherapy, in leiomyosarcoma, another one. So it's so important to understand the differences of sarcoma types and subtypes, because this has a major impact in surgical strategy.
Yeah, it's really helpful, and maybe we can get Dr. Rout to chime in here. One thing that was that struck me was importance of combining a morphologic-based approach, but then also this cytogenic molecular information about genetic alterations in immunohistochemical staining. So when surgeons, perhaps in the community or even at large academic medical centers who don't have as much experience with these tumors, should all of these tumors be biopsied? Should all of these tumors be sent for molecular screening and genetic analysis? What advice would you have for surgeons out there about what tests they should be asking for, sending these tumors for it to be fully evaluated?
Tim, thanks again for inviting us to give this podcast. I think the question you ask is a very important one, and one we see is a conundrum for practicing surgeon. And that is, how do you go about even starting your workup and deciding what to do with these individuals? We tend to prefer getting biopsies on everybody. We tend to prefer getting a core needle biopsy, only using incisional biopsies when we cannot get a core needle biopsy, but we think that we need pre-op therapy. And the reason we do that, we biopsy everyone, is that it does dictate whether or not we use certain types of neoadjuvant therapy. And it also dictates the scope of the operation, because the different sarcoma histologic types have different patterns of recurrence. And we want to make sure we do the right operation based on the specific histology. A common misconception is that biopsies can lead to tumor rupture or can lead to tumor tract or biopsy tract seeding. And really, the data don't support that at all. In fact, when looking at retroperitoneal sarcoma biopsy data, we found that the risk of needle tract seeding is actually quite minimal, and it's less than 1%. So biopsies are safe, and they do dictate management.
That's very helpful. I think that article by Dr. Granchi is definitely an important one for our readers to be familiar with this new classification. And again, really highlighted to me the important advancements around not only the morphologic classification of these tumors, but really the current cytogenetic and molecular classification of these tumors, and how we need to better understand that to inform our treatment. And so I thought, with that in mind, maybe we can pivot to a specific type of histologic subtype of tumors, and that would be desmoid tumors. And this is an article that is written by one of my good colleagues and actually former research fellows, Dr. Gaia Spolverato, that really highlights the advances in desmoid tumors. And I didn't know if Dr. Granchi, maybe you wanted to start us off by just telling us a little bit about the presentation and the kind of epidemiology, if you will, of desmoid tumors.
So desmoid tumors are rare subtypes of soft tissue tumors, not in fact a sarcoma conventionally, because it's not a malignancy, it's an intermediate malignant tumor, because it does not metastasize, the incidence is around 2-5 new cases per million. It is predominantly sporadic, but in 5 to 10% of the cases is associated to FIP in the Gardner syndrome, so to familial adenomatous polyposis. The management of the desmoid used to be surgical for many years. But in the last 10 years, there has been a major shift, a major treatment change towards a more conservative approach. So active surveillance has become the initial approach to this disease, mostly worldwide, and should be considered the primary approach to this disease, because some 50% of these patients do not need any treatment, simply because the tumor will not grow and eventually will regress by itself. And this happens also when it initially grows. So it's really important not to make the patient more morbid than the disease does itself. So I think for me, the bottom line of the treatment strategy in desmoid tumor is exactly this. Don't make the patients more morbid, more affected by your treatment than he is or she is from the disease.
And Dr. Granchi, you mentioned that surveillance typically is the first mode of therapy, if you will. It's not really therapy, but following people. What would be your normal surveillance routine? How often do these patients need to be followed, and which modality is your modality of choice?
We usually use MRI because they are young patients, and most of the time these tumors are located in the periphery, or in the abdominal wall. When they are located in the abdomen, you do use CT scan more often. And we do follow them initially a little bit closely, because you need to try to avoid the tumor to grow and determine cause complications that you wouldn't like to have. So this means that you do it the first assessment 3 months after your diagnosis, then 6 months, and then 6 monthly if the tumor doesn't grow. You usually have some 1 to 2 year time interval to make a decision towards an active treatment or not. So we don't immediately go on to an active treatment, even if the tumor initially progresses, because this may happen, and still you may observe afterwards a growth arrest and then a regression. So it's important to treat symptoms along with observing the patients. So pain control is important. In this disease, quality of life is important. So pain control is important. And so you need to control the pain sometimes without treating the disease. And at some point, when an active therapy is needed, you need to make a choice. Usually, surgery is left last, with some few exceptions that nowadays that can still be considered. And among them, for example, abdominal wall desmoids or mesenteric desmoids in non-FIP patients, though, are classical cases where you can still consider surgery as an option a little earlier than in all other locations.
So maybe, Dr. Ravs, you could build on some of Dr. Granchi's comments, and Alex, symptoms, interval growth for indications for treatment. He highlighted surgery. I was wondering if you could also comment a little bit on some of the other therapies that were mentioned in the article by Dr. Spolverato, as far as systemic treatments and or other local treatments, such as is there a role for radiation therapy?
Yes. So desmoids are obviously, the more we understand about the disease, the more we realize we really don't understand. And I think that we are understanding that this is really rather a complex condition. Just to touch back on a point you made on the prior article, we do think it's really important to biopsy these tumors, because it does help us know whether or not any treatment is needed. If a lesion turned out not to be a desmoid and something that did need surgery, that would be really important. But if it turns out to be a desmoid, we can go down a non-operative path early on. So in terms of the treatments, There are, surgery is not our first line treatment. And I think that's a very important message for surgeons to hear, that we don't jump in and take these tumors out. There are very few exceptions where we actually do that. There are a number of systemic therapy options that are available. One of the most important lessons, and the only phase 3 trial that has been completed and reported, has been on the use of sorafenib. And that did show that there was benefit to sorafenib compared to placebo. But the interesting thing, probably the most important take home that I got from that trial, was that a substantial number of patients, around 20%, get some sort of spontaneous reduction in tumor size with just placebo, without any intervention whatsoever. So that's just the baseline that we're dealing with. That a lot of patients will not need any treatment at all. A number of therapies are effective, including sorafenib, pazopanib, and other targeted agents. Systemic therapy, systemic chemotherapy, such as doxorubicin or liposomal doxorubicin, methotrexate, have all been shown to have some efficacy. There are other drugs that are under investigation, including nirogacestat and a beta-catenin inhibitor, ategavivint, which are still in clinical trial, and their role in the armamentarium of desmoid therapy still remains to be defined. In terms of other local therapies, radiation therapy can be quite effective if surgery and systemic treatment options are not controlling the disease. This is often the case around the head and neck or paraspinal region, where we do use radiation therapy. But given that this is a benign disease, we've really shied away from using radiation regularly. Another local treatment that is gaining some traction is cryotherapy, or cryoablation rather. And so cryoablation can be effective, but there's not a lot of experience. And so there are interventional radiologists who are gaining that experience, but this is a potentially exciting new treatment option for patients with symptomatic localized disease.
Yeah, it's very helpful. And before we leave the topic of desmoid, I wonder, Dr. Granchi, maybe if you could comment, are there any important points for our listeners that would differentiate your approach to the patient who had a sporadic desmoid versus an FAP-associated desmoid? How should our listeners be thinking of those two different entities?
Yeah, thank you. So this is an important question. So for sporadic desmoids tend to be more indolent in general, while FAP-associated desmoids tend to be more aggressive. So the likelihood of obtaining tumor control by surgery for an FAP-associated desmoid is very little. And that's very important to understand. So when you're dealing with a mesenteric desmoid, if it's a sporadic mesenteric desmoid, you can still resort to surgery, while this should not occur if you are dealing with an FAP-associated desmoid. So two kind of different diseases, even if they share a lot of similarities in terms of morphology and also molecular background, but they're different.
That's helpful. Thank you. So I want to move on to our next article, which is an article that was co-authored by Dr. Rout. And I think it's a really important article, a comprehensive article that highlights relevant trials in sarcomas and gastrointestinal stromal tumors. I think our sarcoma colleagues have done a very good job at looking at many different issues in a prospective way using clinical trials. And so this article is important. So I'm wondering, Dr., if you could highlight for our listeners, maybe in your mind, I know there's so many, but in your mind, maybe what are the one or two seminal trials that it would be important for our listeners to know about to inform their evidence-based care of patients with sarcomas or GIST?
Sure. So in this article, what we intended to do was to summarize what are the key articles that have impacted care over the last 30 years or so. Quite exciting has been the Strauss study, which is the first and only completed phase 3 trial in retroperitoneal sarcomas. And this study looked simply at the question of whether preoperative radiation therapy reduces the risk of abdominal recurrence in patients with primary retroperitoneal sarcomas. We know that radiation is quite effective at reducing local recurrence rates in extremity and truncal sarcomas, but there are increased risks with retroperitoneal sarcomas given the surrounding viscera, which can be quite sensitive to radiation therapy. The important take home from the trial was that, in fact, radiation did not reduce the risk of abdominal recurrence across the study. However, an unplanned subset analysis recommended by the Data Safety Monitoring Committee showed that there may be a signal in a specific subset of patients, those with well-differentiated liposarcoma or low-grade liposarcoma, that has not been proven in a prospective trial focusing on that question, and it was an unplanned analysis, but it does change how we can treat patients with retroperitoneal sarcomas by, first of all, not just routinely offering radiation therapy, but considering a more nuanced approach of at least offering it in patients with well-differentiated or low-grade liposarcomas, presenting the trial data with all of its caveats. A second important trial that impacts the management of patients with gastrointestinal stromal tumor is the randomized trial looking at 3 versus 1 year of adjuvant imatinib. The reason that is a seminal trial is that it basically established that longer duration therapy with the oral agent imatinib, a daily drug, not only reduced recurrence, but also improved survival. The outcome there was overall survival, not disease-specific survival, but it did improve survival. And so that is the standard of care globally, to do at least 3 years. There are other trials that are looking at longer duration therapy, and a 5-year single-arm study done in the United States does suggest that at least while patients who are on therapy and have a sensitive mutation, they can get disease control. And maybe we're going to ask Dr. Granchi about his important trials in extremity sarcomas, because I think that is another highlight over the last few years.
So, Dr. Rout, you know me too well. I was actually going to turn to Dr. Granchi now and ask you to comment on exactly what Dr. Rout had mentioned. You know, he had highlighted XRT for RP sarcomas and GIST, but we'd love to hear from you since you're a worldwide expert and clinical trialist in sarcoma.
Yes, sure. So I believe that the study that were done on neoadjuvant chemotherapy in high risk of extremities of tissue sarcoma and tranquil soft tissue sarcoma in the past 10 years were very important, because they were able to help understand two things, basically. Number one, you know that chemotherapy, the role of chemotherapy in high risk of tissue sarcoma has been debated for many years, while these trials were able to understand which patients to select to consider neoadjuvant chemotherapy, because by means of a very easy tool. So and this tool is a nomogram, basically. So a nomogram which is available on an app that can be downloaded free from any platform for Android or Apple devices. And this app is called Circulator. And this nomogram is calculate basically the risk of the single patient of developing distal metastasis and his survival probability. So by using a cutoff, the 10-year survival probability, we're able to identify patients at a higher risk of death. And these patients were the ones benefiting from neoadjuvant chemotherapy. So we were able to show, number one, that neoadjuvant chemotherapy is effective, and number two, which are the patients that should get it. So I think that the evidence raised so far by these trials and some reanalysis of some older trials by these tools were very convincing to, at least to many, medical oncologists, maybe not to all, but many medical oncologists and surgical oncologists, to consider neoadjuvant chemotherapy in the very high-risk population.
Yeah, thank you. That's interesting. I'd like to move on now to our final article that we're going to be discussing today, which is on immunotherapy. And Dr. Tellez was the primary author on this article. Now, obviously, there's been a lot of interest and excitement in immunotherapy as it has applied to many solid malignancies, and sarcoma is definitely one of them. So maybe we can start off with you, Dr. Rout, and maybe you could just highlight for us some of the advances in immunotherapy as they relate to sarcoma, and in particular, what specific histologic subtypes has immunotherapy really moved the needle for over the last number of years?
Sure. So what's surprising is that it was all the way back in the 1890s that Sir William Coley observed that sarcomas could be susceptible to immune recognition and attack. And yet, in the intervening 130 years, very little advances have been made in immunotherapy for soft tissue sarcomas. And even unlike other malignancies, sarcoma has really been lagging behind in effective immunotherapies globally. And I think part of the problem has been that in general, sarcomas are immunologically cold. They have sparse immune infiltration, and as a group, there's been a generally poor response to immunotherapy. However, as you mentioned, there are some subtypes where we do see efficacy, and I think that the way the sarcoma community has moved recently is to do histology-specific immunotherapy trials. And when we asked the authors to come together for this paper, we wanted to invite the real experts in immunotherapy in sarcoma care. And what we found with their work is that there are certain subtypes such as alveolar soft part sarcoma, angiosarcoma, particularly those which have a high tumor mutational burden, and a few others, including dedifferentiated liposarcoma, unclassified pleomorphic sarcoma, where there may be some benefit to immunotherapy. And even within those subsets, for instance, within angiosarcoma, it may be just that group that has high tumor mutational burden. Those typically are the ones that are due to sun exposure, such as the head and neck ones, rather than, say, the primary breast angiosarcoma, where their tumor mutational burden is low. So there are advances that are being made, but these are now coming at a specific histology level, and there's a lot more to come in that arena.
Thank you. So maybe Dr. Granchi, we could tease this apart a little bit more, and in particular, I'd like to hear a little bit more about the different types of immunotherapy and how they may relate to sarcoma. Obviously, immunotherapy is kind of a little bit of a catch-all, and I was just wondering about the role of checkpoint inhibitors versus some adoptive cellular therapies, whether it be TIL therapy or CAR T therapy. What may be the different roles for the different types of immunotherapy related to sarcoma?
The drugs that were studied the most in sarcoma were certainly checkpoint inhibitors, mostly pembrolizumab, but also a few others. And what was found beside different sensitivity in the different histology types was also possibly and the presence of a biomarker, which was kind of predictive of the efficacy of the drugs. And this biomarker is the presence of tertiary lymphostructure in the tumor. So the presence of tertiary lymphostructure in the tumor is so far, at least in sarcoma, regardless of the histology type, seems to be, actually, I would say, it's not super validated prospectively in a very large number of patients, but it seems to be the most attractive and effective biomarker which predicts the activity of the drugs. And there are actually attempts now to study these drugs also prospectively in the localized setting, because chemotherapy can induce the presence of tertiary lymphostructure in the tumor. And this may open a completely new field of investigation for the years to come, also in localized high-risk sarcoma. In terms of other immunotherapy drugs, like, for example, adoptive T-cell therapies, this is used basically only in mixed liposarcoma and synovial sarcoma. We are, thanks to the presence of NY-ESO-1 antigen. So in these two specific histology types, there are attempts to study the use of adoptive cell therapies, and which seems to be effective, but they are complicated by the fact that you need to be HLA-2 competent, because if you don't have the right HLA-2, you can't use these drugs. And the prevalence of this HLA-2 in the mixed liposarcoma and synovial patients is far from well understood, and it seems to be also related to the race, basically Caucasians, Black Americans, or Italians, for example. It's very much not present in Italy. And lastly, the role of CAR T-cell and TIL therapy is still very experimental in sarcoma. It's not used routinely.
Yeah, I'll jump in there. Just the adoptive cell therapy, potentially new and exciting. Right now, it's just very limited data coming out of synovial sarcoma, myxoid liposarcoma. I think one important trial that's we're going to hear data from soon are the use of neoadjuvant radiation plus neoadjuvant and adjuvant pembrolizumab, a randomized trial for localized extremity and trunk unclassified pleomorphic sarcoma and dedifferentiated liposarcoma, which could be a practice-changing study. So exciting news to come soon on that.
Well, that is very exciting. I think, again, this volume of surgical oncology clinics is an extremely important volume for anyone who is interested in this topic and seeing patients with this disease. And again, I want to thank Dr. Rout and Dr. Granchi for their editing of this volume and all of the co-authors of this volume who really did an outstanding job putting this material together in a very accessible way, in a state-of-the-art way that I know our readers will enjoy. So Chan, Alex, thank you both so much for all of your hard work and for taking time today to join us on the podcast.
Thank you, Xavier.
Thank you.
Thank you for joining us for this Surgical Oncology Clinics podcast devoted to sarcoma. The 4 articles discussed, as well as 10 others, are in the July 2022 issue, Volume 31, Number 3. The series is available for individual print subscription with online access or individual online-only access. Visit www.surgonc.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter at Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Amazon Music, Spotify, or Stitcher. Thanks for listening.